time in your atlas, and then making sure you're able to relate that to the body parts is good. So let's have a word of prayer as we begin. Lord, we thank you for your blessings and for sunshine. We thank you for the opportunity to be here as we continue to move forward and strengthen us during this time. We have about 2 weeks really to finish this all up. So we ask that you will be with our health, be with our mental health, physical, spiritual, and all the others as we are looking forward to getting to our break after saying, man, we did the best we could, and thank you for your blessings. In your name we do pray, amen. Don't be dismayed by your grade in the class. It's not a raw score that will give you your grades. Okay? This class is meant to be more so like medical school. It's slower, but it's more so like it. And so, and we're not doing a whole lot of the blue boxes. Like if I would probably, to be more so like the school, I'd be adding a whole lot more of the blue boxes that you see and more. I'd be going over a lot more of those things to hone in some of the clinical aspects of things. So I bring in some stuff, but you're not responsible for knowing all those things. But even with that, even in medical school or dental school, you're not expected to know all of the clinical stuff anyway, because you're like a first year, second year. So really they focus on, if you know the anatomy, then you can answer those questions, regardless of what weird name they throw out there. As long as you understand the mechanism. Hey, there's some kind of weird thing going on, but he can't, move his arm, like this. You're like, okay, well that's messed up. That's probably biceps. We're looking at what? Muscocutaneous or something like that. And so these are things that, even though you don't know the particular lingo of it, you'll be prepared for it. So I need to ask a couple more questions, but I'm encouraged that some of our freshman students in medical school have given me some feedback and said they're doing well. They passed their blocks, in this class, and the way that we have the questions being asked helps prepare them for the questions they'll see in the future. So just know this is some growing pains right now, but when you see it again, you'll be like, I'm used to this, I've seen this before. And you can focus a little bit on some other class that maybe, biochem or something. It may be a challenge, who knows. I just want to encourage you as we're moving forward to just do your best as we move forward. Now, the essence of these exams, I did open up and add on some things to D2L. So you should see a review, a general review sheet for the pelvic exam, a general review sheet for the final exam as well. And I'll be going over that on the contents folder. If you just kind of scroll down, not in the weeks, but I think all the way down near the bottom, you should see some of those things pop up. And you can use that as a guide. For the pelvis exam, this will probably be the exam that the PowerPoints actually help a little bit more than usual. Normally you're like, okay, I went through the PowerPoints and I took the test and man, what is this? This is not sufficient. Because why? The atlas is most sufficient. More tables and some other things are more sufficient. But this one actually near the end, there's certain parts of this that actually kind of help. So you still need to understand and look at the, I forgot to add something to the PowerPoint. I'll have to add it later. I try to add some other things today. But what we do have is understanding the structures that are there. It's still, I'm sorry, you're cheating yourself if you do not know your atlas. If you don't know your atlas, you're cheating yourself because that is the essence of you need to be able to see the structures and know where they are. And so that's the reason why we have these practicums and stuff like that for you to develop those skills, whether you want to or not. So for those of you coming next semester, I'm telling you, as soon as you start a chapter, you just start looking at the atlas, look at the pictures, see what's going on, and next thing you know, you'll see stuff in class and be like, oh yeah, I remember seeing that. You'll have questions and you'll be able to answer them because you know what the structures are. So I'm just letting you know there's no cheat code to it. You just have to know the stuff from where it is. Relationships are everything because that's how they test you. We're going to hone in on a couple of those things today as we go through for all you budding OBs, OBGYN specialists as well. We'll talk about some of these things today. Okay? So, want to encourage you guys, hang in there as we're moving through this. So we've gone through about half of this, and so when we talk about these things, the pelvic girdle, these hip bones that are there, they bear weight, you're able to transfer your body weight with these. Protects the organs. We talked a little bit about the transmission of this, the sacroiliac joint, the way our axes of rotation is there. Definitely need to know greater and lesser pelvis, right? So greater and lesser pelvis, the pelvic diaphragm is very important, but also for clarification, the pelvic diaphragm, and it has it on this slide, but this is a little bit misleading. Pelvic diaphragm is not the levator ani. There are muscles which we call levator ani, which are three muscles that help to make up the pelvic diaphragm, but it is not the same. Okay, so it's just think about the levator ani muscles as a subset of your pelvic diaphragm. That's there. So we want to make sure that's clear. Perineum is down below the pelvic diaphragm. That's there as well. So we talk about false and greater and lesser pelvis. Here are the bones. Make sure you're comfortable with the general structures that are there. I'm trying to remember if I have any questions on the actual hip bones themselves. I think maybe on not much. I know I cover this a little bit more as well when I do the legs, but just go ahead and reacquaint yourself with the parts of the bones, just in case something pops up on your exam. Let's see. Difference between male and female pelvis. I've definitely asked the question on this. So make sure you're comfortable in understanding the differences between males and females that are there. Just remember, males are more thick and heavy, they're more upright, has a deeper, greater pelvis that's there, whereas the females has wider, has thinner, lighter, has a wider angle that you have from the pubic arch that's located in this area. It's more oval versus heart shape that you have for the male. And so make sure you're comfortable in understanding the differences between male and female pelvises. Talk about walls and floor of the pelvic cavity. I don't recall ever asking a question on these. But for your own edification, you need to understand where these structures are. So just make sure you're comfortable in knowing this. I don't recall asking a question on this. The anterior and inferior wall formed by body's ring modular bones bears the weight. It's there. We have two lateral walls, right by the hip bones. Obturator foramen and the membrane. Remember, it's covered over by a huge muscle and a lot of other structures that cover over the obturator foramen that's there. Posterior wall, sacrum, coccyx, sacroiliac, sacrospinous, sacrotuberous ligaments, and piriformis muscle that's there as well. And we kind of walked through these a little bit, showing that we at first had, this thing just looks like this, right? This is our foramen, obturator foramen that's right here. But remember, it's all covered up. It's kind of wild that you have a big old hole there, but maybe through development, stuff kind of grew in through that hole and then affixed to each side. But anyway, coming through is a very small area. And so as we walk through this, we noted that first you would have, here's our sacrum, here's our pubic bone, here's our brim, kind of in this way, making sure this is the lesser pelvis is actually more the greater pelvis up here. You can see you have your soon-to-be femoral vessels that are coursing through this area. And here we have the obturator nerve. Remember, obturator nerve comes down here. It's 2 through 4. It basically comes through this area and goes through the obturator foramen. But remember, it has a big old hole. All of this is obturator foramen, and it only goes through this little part. So we have that there, and the obturator membrane is located in this space. We have different ligaments, and as we said, the ligaments are just named according to what they're touching. Since this is the ischial tuberosity, and this is our sacrum, this is our sacrotuberous ligament. So that's kind of how they name it. This is the ischial spine, this is the sacrum, so they call it sacrospinous ligament. It's there. So these are the things that are in that space. As we move down, and we can see a little bit more underneath this, note that we do have, as these vessels are coming through, here's our same obturator nerve that's here. And now covering up even more is the obturator internus muscle that is located here. Obturator internus muscle that's here. We have a coccygeus muscle on the back side, and some, how do you say, sacral vessels, nerves that are running through here as well. As we move over now, we can see more of what we consider the pelvic diaphragm, including the levator ani muscles. And so this includes the obturator nerve that runs through. Again, some of our sacral plexus that are coming through these vessels. And the internal iliac, external iliac, external artery and vein, internal iliacs, of course, are coming down through here. And you have this kind of tendinous arch of levator ani that's here, including the iliococcygeus, the pubococcygeus, and puborectalis. So these three muscles make up what we call the levator ani muscles. In addition to the pelvic diaphragm, we add the coccygeus muscle that's here as well. Yes?
What three muscles?
These three.
Okay.
Iliococcygeus, pubo, and puborectalis. And we'll see those in another slide as well. And the coccygeus is just in addition to the pelvic diaphragm that's there. All these muscles are helping to hold us together when we're coughing or laughing really hard or anything causing a vagal response. Valsalva maneuver. Valsalva is when we're contracting against the closed glottis. So anytime you're bearing down, these guys are holding us up. So we're very thankful for them. That's there. Again, here's an image that we see, and this is somewhat review, but I wanted to make sure that those that have been traveling, welcome back, by the way. Glad you guys made it back safely. I've heard great responses from folk. Who was it? Ben. Alvin Chia, base for Take 6. He was like, man, all I can say is it is so good to hear the aliens again. Like, man, Heritage is what's up with OU. So proud to be an OU. So whatever you guys were doing, whatever you guys were saying, it must have been angelic, as usual. So we want to celebrate you guys. And now welcome back to the real world. we're on the grind. But here you can see these muscles that are here in this space. So we have these different holes where things are coming in. Note that we do have this early muscle attaching to this pubic bone. Again, these are named according to where they're going. So here's our pubic bone, here's the rectum, right? So this kind of goes, it's like a slingshot running around here. So these are our puborectalis muscles. Puborectalis muscles is going from here to there. Then we have a pubococcygeus. So you know the coccyx is back here. So this one runs all the way back here and attaches. And this other one runs back here and attaches. So this is a pubococcygeus muscle that we have that's there. And then we have one attaching from the ilium to the coccyx. So they call it the iliococcygeus. So these three we consider the levator ani muscles. Coccygeus is the muscle that's behind it. So we can actually see the coccygeus that's back here, attaching in this space. And even further than that is a piriformis. Now, this piriformis is a muscle that comes out of the posterior aspect of the pelvic region and goes and attaches to your femur. And so in doing that, it allows you to do more, I guess you could say, more of a abduction from the legs in that area. And so this allows for those things. Now, the challenge with the piriformis muscle, I think I mentioned last time as well, is this relationship to the sciatic nerve, which runs down the back of your leg. Again, this is a really fat nerve, and you'll see it next semester. But essentially, sometimes the piriformis can be really tight. And if that's the case, then it can actually impinge on the sciatic nerve, causing sciatica, which is these shooting pains or sensations going down the back of the leg, which causes problems. So it's it's good to understand that relationship where the sciatic nerve actually runs inferior to the piriformis muscle. So we do have the coccygeus and these three levator ani muscles helping to make up that pelvic diaphragm that's there. We can also note that we do have these sphincters whereby we can, close off stuff. So here's our vaginal region, a urethral region that's here as well. And the sphincters are around these areas in order to turn, basically turn off the water for anything that's going on. Again, we do have different somatic nerves in the pelvis. Somatic means these guys are going to skeletal muscle. So that's where we have the L4, L5, and all the sacral nerves, etc., the coccygeal nerve, going to different things. And so here we can see branching off of here, we have the common fibular and tibial nerves. This is what makes up the sciatic nerve. So these two make up the sciatic. We have posterior femorocutaneous as well, going towards the skin. But in general, this is what makes up the sciatic nerve that runs down the back of your leg. We'll explore this more so when we get to the lower extremity. Just wanted to show you the relationship. See how these guys are all coming out of here? The piriformis muscle is running across here, and this guy is coming out below that, causing some issues. Now we do have one nerve that's very important as well. If you know, coming from like S1 through 4, sometimes they say 2 through 4. It's called the pudendal nerve. So the pudendal nerve comes down and goes to our private parts. This is a very important nerve. If this is severed, folk are having fits, understandably. Loss of anything down there is a big loss. And so this is a nerve to remember. So sciatic, yes. Pudendal, definitely yes, in terms of understanding nerves that are there. We will go over these other nerves next semester when we cover nerves going to the particular muscles behind that, gluteal muscles, etc. Again, so our arteries again, just showing you the relationship of these structures coming down. We have our aorta, the renal arteries over there, testicular gonadal arteries, inferior mesenteric artery. You guys should know these structures by now and be able to recognize them in the body. We have our psoas major in the back, our quadratus lumborum that's back here as well. So the muscles back here. Here's our iliacus, combines with the psoas to make that iliopsoas muscle, which is our strongest contractor that we have. Note we have the common iliac, the external iliac, and the internal iliac. So internal iliac is hitting up everybody. So bladder, everybody else that's in here, the internal iliac artery will help supply these guys to make sure they get proper vascular nutrients to where they are. Kind of neat, these little adrenal glands hanging out here. It's weird. Little adrenal glands, notice they just look like fat, and in the body, as you noted, they also look like fat. So it's kind of hard to distinguish where in the world the adrenal medulla really is, But it is there, and these are the guys that release adrenaline and things like that for your body. Yes, this dot matrix version of the image also shows you the relationship of some of the portal venous system and also the inferior vena cava that's here with its particular branches that are coming off, specifically coming down into this space as well. Yeah, threw that one in just so you can see something a little bit different. I just threw that in this morning. It's not really a good picture, but it's better than the dot matrix version, I guess. Except it doesn't include IVC. This is only the portal venous system that's here. So I'm going to have to find some better things to upload to here. But it lets you at least see what's happening. So the pelvic viscera, we do have varied pelvic organs, bladder, parts of the ureters, organs of the reproductive system, the distal part of the gastrointestinal tract, the rectum that's down there. So again, for the urinary system, we have ureters, bladder, and urethra, right? So we have several ureters depending on how many kidneys we have. Most people have 2. You may have 3, may have 4. Just kind of depends on, you know, how the person came out. And so usually it's 2, but you may have more. And therefore you may find more ureters that are coming down to the bladder. Yes?
Are these extra,
Yeah, they're active. So when you shut off that supply, then the other guys just work a little bit harder. But yeah, it's like they're super efficient. You know, you got 4, man, you're really ready to filter the blood. And forget dialysis, you know, I got 4 kidneys. You know, so it's actually good to have these things. Anyway, so we note that relationship of these structures though as well, where we have these ureters that come down through here. They run right into the posterior aspect of the bladder at what they call the trigone portion of the bladder. And then from the ureters, the bladder stores the urine, and then from the urethra, that's where we have it from the bladder going out in that space. Also note the relationship of these structures in the abdomen, or when we get to celiac trunks and SMAs, IMAs, and all that stuff. Make sure you're comfortable in understanding the relationship of these structures that are there. But, yeah. Okay, so again, in infants and young children, the urinary bladder is in the abdomen, remember? So it starts in the abdomen, it's hanging out there. We wait until how long before we pull the testes down or anything else? We'll come back to that question. So, but for the bladder itself, in infants and young kids, urinary bladder is in the abdomen. It enters the greater pelvis by age 6. When do we normally potty train? We were like, man, I had to be in preschool, so I was potty trained at 2.5. I don't know what you're talking about. But you know, we can be day potty trained. We can kind of figure it out. Night potty trained, you know, it goes on. So it enters the greater pelvis by age 6, and after puberty, it enters the lesser true pelvis. Can you believe that? It takes that long to kind of just hang out and come on down where it needs to be. That's the reason why you may have folk, you know, at night, you know, still wet in bed. You're like, man, how old are you, man? I'm just, you know, I'm just, you know, doing my best, you know. But it's real. But usually, kids, by the time they're about 7, we expect them to be night potty trained and everything. By the time they're going to school, we expect them to be night potty trained by then. If they're having challenges at that time, they mess up once or twice, but if they are messing up kind of consistently, we need to check out and see if there's anything else. Anyway, after micturition, which is urination, the bladder empties completely, you know, unless there's an obstruction that's there. So, as I said before, you go to the bathroom, and you can't just stop midstream and be like, I'm done. You have to make sure that thing empties on out, whether you like it or not. A bladder bed includes the structures that have contact with it, such as the pubic bones, the levator ani muscles that are there, superior obturator internus muscles, and the peritoneum as well. In males, we have the seminal vesicles, ductus deferens, should be C, that's here, prostate glands, and female superior anterior wall of the vagina is there as well. So here's our bladder, male or female? All right, so male or female?
Male.
Okay, so 50-50 sounds like. Female or male?
Male.
Okay, I have somebody yelling male. Why do you think male? Yeah, prostate's here. So this is the prostate gland that's here. So prostate's here, let us know. Yeah, this is a male in this case. So here's a bladder. Here's a trigone. They like to harp on the trigone. That's the entry point where you have the ureters coming into that space as well. The muscle around the bladder itself is called the detrusor muscle. Detrusor muscle. And this one helps to contract down fully in order to get that urine on out. Here's some of the pelvic diaphragm that we can see here. Here's the intermediate diaphragm. It's going across where we have, for example, this external urethral sphincter that's here, helping to externally try to cut this thing off. We have an internal urethral orifice and sphincter associated here as well. We'll talk about that a little bit more in a moment as well. So notice you have an internal urethral sphincter and an external urethral sphincter for the bladder. 2 for 1. All right. So again, the urinary bladder is here. It's more anteriorly, as you guys have seen. It's subperitoneal. And from that, you have, just showing you the relationship of these structures. Here's the umbilical artery that comes all the way up. Going to, of course, was a remnant of what we had initially as well, but the umbilical artery that we have in this space. Anything else that's important here? Not really. Just notice that whenever they say fundus, it's always like the rounded part of something. That's kind of what you can note here as well in this space. So when you enter the bladder, it's tetrahedral, has an apex, which is anterior superior in the front. So apex in this case is in the front. Fundus, posterior aspect, the body and the neck associated with the bladder as well. There's a trigones where the ureters come into. Reflux urine into the ureters is prevented by the muscular sphincter around these orifices. So it allows for urine to come in, but it doesn't go back out. And this is good, because if our bladder got bigger and bigger and bigger, and then that urine started backing up, you can see who gets messed up. Yeah, the kidneys. So you have some kind of nephritis going on, which we don't want to have that. It's all bad when you get into the kidney, start messing with that. So in males, the internal urethral sphincter prevents ejaculatory reflex of semen into the bladder itself as well. So sympathetic nerves stimulate the sphincter. In general, when you think of sphincters, think of sympathetic control, being able to control what's going on. Anything that can help to close up stuff is you're under that sympathetic control that's there. This is also somewhat important as well. If you have a patient that comes in and in their urine they have semen, some ain't right. They should not be, they do not mix. So I guess we'll be going to it in just a bit anyway. But for males, they have 2 pathways, okay? Two gates that guard those things, and they do not mix. Whereas in females, they have their own little pathway for the urine itself as well. So we'll take a look at these in a moment. We do have branches of the internal iliac arteries. Different plexuses help drain the bladder itself. Lymphatic vessels are around the bladder, pass through the internal and external iliac lymph nodes, which makes sense. Those are the vessels that are nearby. Sympathetic and parasympathetic nerves regulate the functions of the bladder. Sympathetic would cause it to do what? For the bladder. Bladder under sympathetic control does what? Okay, somebody said controls the sphincter, causing it to. All right. So I think maybe you're giving the right answer, but maybe I'm hard of hearing. What you said? I didn't hear what's going on. So I think sympathetic control of the bladder means the bladder is going to do what? What? Hold it. Yeah. Hold it, right? Okay. So bladder, we're going to hold it under what? Sympathetic control. And so for parasympathetic control, the bladder does what? Let it go. That's right. Releases. So relaxed. This is so fantastic, right? So again, I tell you, man, next time you're stressed, man, you may be able to hold that stuff a little bit longer. Start running in place, man, if it's time to go. I'm telling you, them kids got it early on. We look at them, we're like, why are they running? Oh, that's why. Anyway, just kind of making sure we're comfortable with that. So male urethra is longer than the females. Again, it's about 22 centimeters long. We have the prostatic urethra, the intermediate or membranous part, and also the spongy urethra. Intramural or within the mural part of the urethra, pre-prostatic urethra is proximally segmented. proximal segment of the urethra itself. We'll take a picture, images of these in a moment. Ejaculatory ducts are sites of ductus deferens opening into the urethra, adjacent to the prostatic utricle. The proximal urethra is supplied by branches from the inferior vesicle and middle rectal arteries that are there. And prostatic venous plexus drains this proximal area, and innervation is accomplished by this prostatic plexus. So here we're looking at the male urethra. Here's the bladder itself, and these are all the pathways. And so there's a prostatic urethra that's going dun, 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 dun. So it's stuck in the prostatic urethra, then it continues on, dun, dun, in the intermediate part of the membranous part of the urethra that's located here, dun, dun. Now it's in the spongy urethra as it comes through this area. So we went from prostatic to membranous to spongy, and dun, dun, yeah. And so it runs on out into the toilet there and it's happy. But this is the pathway for it coming through. This is also the pathway, the same pathway for semen to get out. Semen actually comes out, it starts coming through here and then runs through. So there's these spaces that are coming through the base of this, kind of the base of the bladder area, but it's really coming out through the prostate region where we start having semen that's coming through connected with the vas deferens. So it's going through the same pathway. Like I said before, you can't have two guys coming through the same area. It's not going to be urine and semen as well at the same time. So you have to shut this stuff off. What if I saw a patient and I did a scope, okay, and went up into the bladder itself, and I started looking in there and I saw urine and semen? What's the problem? The what? Yeah, well, possibly, if there's some barrier that's been broken or some other issues. But what is the, how do you say, what is the problem, what is the likely problem of finding semen in the bladder? It's not supposed to be in there. What may be a possible cause? Of things we've kind of mentioned a little bit earlier today. The sphincters are open. Okay. Which sphincter specifically are we looking at? Because we have an external and an internal sphincter. Right. So you likely have problems with that internal sphincter. Something's not right. And so we need to go and do some analysis on it to say, hey man, this ain't right. That internal sphincter is supposed to work. Maybe there's problems with some nervous innervation to that area. Maybe you lost some of its sympathetic strength. You know, who knows? But yeah, these are things in which you would be looking at. So all you budding urologists, this is your world. Okay. All right. We do have the bulbourethral glands as well. Notice these bulbourethral glands that you can see here that also contribute to semen as well as it's coming out. So you see the penis that's here. Here's the root body and the glands. Glands is the top area that's here of the root. Of this, we are in the spongy urethra. This is the corpora spongiosum that's around here. That's kind of the outside here. And then we have the corpora cavernosum. Cavernosum, you can see a portion of it right here. We'll see some more later on. Other parts, they call this corona, navicular fossa, external urethral orifice. This is the glands. And there's also prepuce, that is kind of the foreskin that is not shown. Female urethra is about 4 centimeters long. So males is what? 22. Female, 4. Let's just say 24. Okay. So if we're dealing with that, as I said before, I think it was last time, this is the reason why it's more likely that females have urinary tract infections. It's just much shorter. It's easier for bacteria to get into those spaces. So that's the reason for all the things that you see on the shelf. External urethral orifice is located in the vestibule in front of the vaginal orifice that's there. We have urethral glands that are on lateral sides of the females that are there, and they're homologous to the prostate gland in the male. So there's several homologs that we have between males and females, and we'll go over that near the end.
Urethra is supplied by the internal pudendal and the vaginal arteries that are there. So urethra, internal pudendal, vaginal arteries. Venous drainage is accompanied by the internal pudendal and vaginal veins. And in both males and females, lymphatic vessels drain this path through the internal iliac lymph nodes as usual. Male and organs includes the ductus deferens, beginning at the epididymis and joins with the seminal gland duct, forming the ejaculatory duct. We'll see an image of this in a minute. The seminal glands are about 5 centimeters long. They lie between the fundus of the bladder and the rectum. They secrete this thick alkaline fluid, which contains what? Yeah, fructose and a coagulating agent. Fructose, what? Yeah, man, sugar. You need some energy, right? These brothers are swimming. And so they need some energy bars in order to get where they're going. So that's why they had the fructose there. And why is this alkaline fluid there? Well, because the vaginal area is what? Has a lower pH. And so alkaline fluid, man, they're coming in like trying to wrap up and say, man, we need to be wrapped up. We're coming into an acidic environment. We need some alkaline. So they have alkaline and fructose snacks, which helps them to, as they're passing. Prostate gland is also an area that's about 3 centimeters long, 4 centimeters wide. Surrounds a prostatic urethra and secretes a milky, slightly acidic fluid. So it has a little bit of acid in it. With the prostate gland, a lot of the alkaline is coming from the seminal glands that are there. And then we have the bulbourethral or Cowper's glands. These are 2 pea-sized glands that we saw, those yellow ones that we saw here. Okay. And so these particular glands release mucus-like secretions during sexual arousal. Helps I guess, lubrication a little bit stuff as well, but also assists in protecting. So the whole purpose of this is really for protection. Try to protect the sperm as best they can because they're swimming through, they need energy, and they're trying to get to where they're trying to go. So this is kind of what it looks like on the posterior aspect of this, where we have the bladder that's there, we have the seminal vesicles that are here. Here's our prostate gland. And this is where the bulb of the penis, in this particular area, we're looking at the spongiosum in these areas. Here's our membranous area, perineal membrane. Here's the Cowper's or bulbourethral glands located here. And some of our levator ani muscles as well. Note that we have the inferior vesicular artery. Why? Because it's dealing with the vesicle, which is the bladder in this case, helping to supply the vascularity to it. Here's our ureteric artery with the ureter coming down into the posterior aspect of the bladder where we see the trigone. So again, these seminal vesicles secrete that alkaline fluid and there's little fructose bars that are there. The prostate gland gives a slightly acidic, milky fluid, and Cowper's glands release some of that mucus aspect to it as well. So the vagina is a musculomembranous tube, 7 to 9 centimeters. Extends from the cervix to the vestibule between the labia minora, contains vaginal external urethral orifices and opening for these vestibular gonads that are there. Vaginal fornix is a recess around the cervix. I think we saw that a little bit on the model in the lab. And so the posterior is the deepest part of the fornix that's there. Then we have lateral and anterior fornices. So when you're doing a pap smear, pelvic exam, whatever it may be, you'll look and see that the cervix is kind of there. It's like a round half dome that's there. So the round half dome is there with a small opening that really isn't open. So around that dome are what we call the fornices. That's where the fornices are, okay? And so those fornices, just know that the posterior is the deepest that's located in that particular space. Now the muscles that compress the vagina and serve as sphincters are these guys, pubovaginalis, attaching to the spaces that you would think. Pubic area in the vagina. External urethral sphincter, urethrovaginal sphincter, and vulval spongiosus that's there. We'll see some images of these in a minute. These uterine branches of the arteries, vaginal and internal pudendal arteries, also supply the vagina that's there as well. So remember, again, these arteries, uterine arteries, internal pudendal arteries, they're everywhere. Drainage is by the urovaginal venous plexus, and innervation by the deep perineal nerve and the uterovaginal plexus. So deep perineal nerve, very important for that area. And this is what the female genitalia, the organs look like. So we do have the labium minora, located right here. This is the vestibule of the vagina that's here. Here's the actual vaginal canal that's here. And this is where we see the cervix. Here's the cervix. And here's a fornices. These are the lateral fornices we can see on the side of that cervix that we're talking about. This inside, of course, is when we get into the uterus. So all of this is the uterus that's here. And there's different layers to it. There's the endometrium. Endometrium is, of course, the internal layer, which is sloughed off on average once every 28 days. Then we have the myometrium, which is muscle that's in that area for contractions, other things. And the perimetrium, or the outside of that outer layer of the uterus that is there. So the fundus, once again, the rounded area of the uterus we can see here. And then we have the fallopian tubes, or uterine tubes on each side. And these are broken up into different parts that we will name in just a moment. Understand that you also have the ovarian ligament and the ovary itself that's located here. Okay. Suspensory ligament also helps to hold up the ovary on the outside. With the ovary itself, you guys have probably gone through physio, you've gone through gen bio, you understand the cycle, have to eat the follicles, Gaffian, antral, does it ring a bell? Okay, no, okay, well, you'll see it in the future. Okay, so basically during cycles and stuff like that, we have the eggs that are already made, they're pre-made right before birth for ladies. And so they're all there hanging out, just chilling, all 400 of them or whatever. And they're hanging out, and once a month they finally say, hey, it's my turn. And they start developing. That's where we have corpus luteum forming, corpus albicans, corpus luteum that comes around. And day 14, the egg pops out. Now, as it pops out, this is what we call what? When the egg leaves the ovary. Ovulation. Yeah. So when this occurs, then the egg is like, and then it goes over here, and here's the little fimbriae of the fallopian tube, and it goes whoop, and just comes on in here. As it's running through, and then it gets implanted in here. Now, normally when sperm is coming, sperm is like, hey, we're trying to find you. And so it's running up here. Usually the part of where the sperm and egg get together, most of the time is actually up in here. So sperm swim, and they a lot of times find the egg right here in the ampular region of the fallopian tube. That's where they get together and hold hands, and then finally go and implant, and we go from there. Note we do have different ligaments that are associated with this. We have the broad ligament that kind of encompasses all these things that are here. There's a uteral tubal junction. There's again the uterine tube, or the fallopian tube that we may note that is located in these spaces. Okay. So uterus is a pear-shaped area. It's tipped anterosuperiorly and relative to the axis of the vagina. So the vaginal canal kind of goes like this. The uterus is usually like this. Okay? And you can see that partly in the lab, I don't know. But you can definitely see it on the model, where it's actually kind of like this. This is the uterus here, the vaginal canal is like that. So they call that anteverted compared to where the vagina is as well. It's also bent anteriorly, so it's kind of curved a little bit. And so they call that, relative to the cervix itself, so they call that anteflexed. So anteverted compared to the vagina, anteflexed compared to the cervix that's there. And its mass rests over the bladder itself. Since it rests over the bladder, what do you think happens during pregnancy? Symptoms for the mother that has a growing uterus. Yeah, man, so that bladder that used to expand and hold 3 liters of fluid now has something laying on it. So you can see now why the mother's like, I gotta go to the bathroom again, and I'm just trying to watch my show. And this is because it's pushing on there. So all y'all cause your mother problems at one time or another because of this. That's what's going on. I guess me too, right? That's what's going through. So regions of the body of the uterus include the uterine body and the fundus. Isthmus is a small area where the uterine tubes enter the uterus. So first we have the fundus, and then we have isthmus, which is a smaller, like isthmus, the strait, these different types of smaller pinched off areas that we see in waterways. We have an isthmus that's there as well. Then we have the cervix, where the vagina joins the reproductive tract. So we'll see another image of these. We have different layers, parametrium, myometrium, and endometrium of the uterus, as we said before. Round ligament of the uterus is attached to the uterotubal junction. Okay? Round ligament attaches to the uterotubal junction. The broad ligament is a double layer of peritoneum. That's what wraps around all of the fallopian tube and everything. So when you go and you look in the lab and you look down and you saw the uterus is there, and it's like it's covered over with, stuff. And so that's essentially what we're looking at. Once you remove the peritoneum, there's also the broad ligament underneath that is also covering over those structures that are there. Mesovarium is a mesentery that holds the ovary itself. Uterine arteries supply the uterus. Uterine venous plexus drains the uterus. And lymphatic vessels from the fundus enter the lumbar lymph nodes that are there. And others are the, again, external and internal iliac lymph nodes. Okay, so uterine tubes, oviducts, or fallopian tubes, are about 10 centimeters long. It includes a mesosalpinx, which is a mesentery that actually holds the uterine tubes that are there. Part of it is the infundibulum, ampulla, and isthmus. So you do need to know these parts. Okay. So infundibulum, ampulla, and isthmus, they're there associated with it. So first coming off is the isthmus. That's where you have the uterine part opens into the uterine cavity. Okay. So if you have the uterus, it's here. The isthmus is the first part. Ampulla is the second part. Infundibulum is the last part next to the fimbriae. All right. So infundibulum, a funnel-shaped opening with finger-like processes or fimbriae that are there. It's attached to the superior surface of the ovary. The ampulla is the widest and longest, and also the area in which usually fertilization occurs. And isthmus, so I, and the A part is where most of the fertilization is occurring. Isthmus of the uterine part opens into the uterine cavity, as we said before. Ovaries are almond-shaped, has oogenesis going on, and ligament of the ovary attaches the uterus at the uterotubal junction as well. Well, the rectum. So it is a segment of the gastrointestinal tract. It follows the curvature of the sacrum and the coccyx itself. There's lateral flexures of the rectum, includes superior, intermediate, and inferior. It just kind of flexes around a little bit like this. There's transverse rectal folds. These are little folds that are kind of going across. There's two on the left, one on the right, okay? And these are just areas in which it kind of helps to keep, things where they need to be. So it's kind of like speed bumps, okay, if you will, for these particular folds. Two on the left, one on the right. So stuff is coming down, and you're like, man, I'm not ready for it to come down yet. It kind of just hangs out there, and it hits the fold, and it's like, next fold, next fold, So it kind of gives you a little bit of help. So your sphincter's not doing all the work that's there. Now the ampulla itself of the rectum is the dilated terminal segment of the rectum that is in that space. And this is what it looks like. Two on the left, one on the right. These are the folds that are there. Note that we do have the superior rectal artery and vein helping to innervate the superior part of the rectum that's located here. Where's this blood supply coming from? Superior rectal arteries. Anybody see it in the lab yet? See it in the atlas? Not yet? Okay. So yeah, it is coming from the abdomen. And so as it's coming out to help supply this area, this is more of the peritoneal aspect, helping to supply vascular supply to the rectum itself. What do you notice here? Here's our middle rectum. Here's our inferior rectum. Where are these guys coming off of? Who's this? What is this? And y'all gotta study these atlases, man. Y'all are sleeping, bruh. What's going on? Okay, so this is the internal what? Artery, what arteries is? The main artery coming down into this whole area of the pelvis. Oh my, okay, here we go. So man, I'm about to be Dr. Durant in here. What? You don't know? Okay, let's get this straight. Okay, so first we have the aorta that comes down, right? Abdominal aorta, and then it splits. It splits into what? Yeah, common iliacs. So it splits into the common iliac arteries. And then the common iliac swims on around to the side, and as the common iliac ends up splitting into what two areas? Internal iliac and the external iliac. Very good. So external iliac continues on around and goes where? Into the thigh. Yeah, and as it goes into the thigh, it changes its name when it crosses the inguinal ligament, and they call it now the femoral artery. Excellent. I knew you guys knew it. So then who's the other guy that goes down into the pelvis area? The internal iliac. And so what is this? Internal iliac coming in there. Okay. So you had it, it was just like, man, it's a different picture. I'm not sure. They're trying to trick you. No, but yeah, so we have the internal iliac artery that's coming down through here. This internal iliac has many branches. We have coming off inferior epigastric artery. Inferior epigastric is actually coming off more of the, it's almost before it comes in. They generally consider that the inferior epigastric coming off. This is a little weird. It's usually they're going to have this coming off a little bit earlier than that. But anyway, the obturator artery. Obturator artery, where does that go through? What hole? Obturator foramen, right. So obturator artery goes through this obturator foramen that's here, a portion of that, and it runs with the obturator nerve as well, okay? We have the umbilical artery. Where do you think that's going to? Yeah, belly button, runs on up and hits some stuff. We have the artery of the ductus deferens. What do you think that helps? Vas deferens, ductus deferens. Interior vesicular artery. Where do you think that's going to? Whenever they tell you vesicle, they're talking about the bladder. So going to the bladder, helping out with that kind of stuff. Inferior gluteal artery. Where do you think that's going? Gluteal region that's there. Internal pudendal artery. Where's that going to? All the private parts that we have around. Okay. So superior vesicular artery as well. Middle rectal artery. So again, these arteries are helping to go to different spaces that are in there. It'll be your job in the future. I'm so mad I didn't put that on there. Maybe you can do a quick Google search or something on that, saying branches of the internal iliac artery. Someone has already done it for you on some notes that are on there. It'll show you the anterior and posterior divisions, and you need to know the anterior posterior divisions and what, in general, the names, basically the names of them. The names will tell you where they're going, and that way you can at least have an idea of where they are. Usually when I was tested on this aspect, they were basically asking, does it come off the anterior posterior division, or what areas of the pelvic area come from the anterior division or something like that. Yes, question, Faith.
Well, yes, I was just going to say, so everything that you just mentioned, like internal, pudendal, inferior epigastric, those are all coming from the internal iliac, correct?
Yes,
Okay.
yeah, all those guys. So the internal iliac splits into the anterior posterior divisions, and then off those divisions, there's those different specific areas that it goes to. So I'd like you to, if it's not on here, I'll try to post something on here, so that you guys can have that for your knowledge library for the future. So again, but what do we notice here? Since this is coming from the abdomen, supplying the superior rectal area, what are these guys supplying? Middle rectal and inferior rectal are supplied by whom? The internal iliac, right. So we actually have collateral circulation that goes on here. If the abdomen's jacked up, I can still get a blood supply to the rectal area. It's okay? If the rectal area is messed up, or the internal pudendal's messed up, the superior rectal can still help out with that. And this is an important lesson to know for almost all the structures that we have in the abdomen as well. there's almost always a collateral blood supply somewhere that's going to help out, give the vascularity to that structure. So just note, and so the importance of it is when you're studying the abdomen or the pelvic area, understanding what those collateral flows are. So you're doing surgery, you would need to ligate something off in order to work on a particular area, where you're going to know that you're going to have collateral flow coming from somewhere else to assist you in that area. Or if you need to ligate both of them temporarily because you really need to have nothing in that area. You see what I mean? So these are the importance of understanding or seeing these structures and understanding that. But they definitely ask questions, standardized board exams on the vascular supply to the rectum itself. Just know abdominals coming from the superior aspect, and inferior takes care of middle and inferior rectal areas are taken care of by the internal dentin. We do have the sphincters that are here. This is a pectinate line, or anal columns. This actually helps separate the difference between what you feel and what you don't feel. So this is more of the visceral feelings that we may have. If hemorrhoids or something are up in here, this would be more of the visceral response. This would be more of the somatic response. We're actually feeling it, more of the pain, etc., with external hemorrhoids in this particular region that's there. Is that okay? So perineum is external surface area in the shallow compartment that's there. There's different boundaries: pubic symphysis, inferior pubic and ischial rami, ischial tuberosity, sacrotuberous ligament, and inferiormost sacrum and coccyx in those regions. I'm trying to remember if I asked any boundary questions for this stuff. Very few, I'll be honest. I'll have to go back and look, but I don't remember having a lot of boundaries that I put on this particular exam. Urogenital and anal triangles. Now those are important to know, especially for the future as well, with perineum, and we'll see that in a minute. Male and female fascia of the perineum. So here are the different fascia that we have with the perineum. All these green lines and some of these others are superficial and deep fascia that you see. So with the uterus that's here, you can see that you have the peritoneum that's on the outside of that. And then you have the vesicular fascia also that's on top of the bladder itself, in this space. From this we have the peritoneum that wraps down like this. Here's the bladder, here's the sphincters. It's located here in the floor of the diaphragm, with the urethra coming out. And we have varied vesical fascias around the bladder itself. We can have membranous or scarpas, which comes down underneath the campers, that runs kind of around here. If you follow that here, you can note that you also have the membranous or scarpas that comes down here and then becomes dartos as we move down into this region. Around the private area, you can actually find some dartos as well here, but around the private area that's here, you have dartos fascia in these regions. Buck's fascia covers all three of these regions in this space. So just letting you know there's different varied fascial layers in these spaces. What else I want to point out of this? That's maybe it. So we're studying the structures of males and females. We've seen this before. So we do have different aspects. So there's the glans, penile raphe, the shaft itself, the scrotal raphe, down, perineal raphe, and the anus that's here. So perineal body is located in between this space and here, males and females, kind of right here. What's called the perineal body is located in this space. This is the corona, or rounded area that we see of the glands itself, and the body, the root, and pubic hairs itself. We have seen this in the lab, and this is kind of the cartoon version of what we're looking at. So this is our spongy urethra. So corpus spongiosum is here with the urethra that's here. Here's a corpus cavernosum. Again, these are two deep arteries that fill with blood. So in this particular space, so during erection, under parasympathetic control, these blood vessels vasodilate, they engorge with blood, allowing for copulation. That's there. We do have a dorsal vein itself. There's a superficial and a deep dorsal vein. two dorsal arteries and dorsal nerves as well that you can note in these spaces. Again, deep fascia and tunica albuginea we can see here, but we can also see that in the testes area as well. Again, just looking at some of the same structures that are here, just showing you some of the dorsal nerves and superficial dorsal veins that are here. Note we have the corpora spongiosum that runs along the base that's here. This is the corpora cavernosum, which is engorged with blood in this space when needed. For the female external genitalia, it looks more or less so like this. And so there's the external urethral orifice that's here. This is where the urethra empties out into. This is the vaginal canal located here. So there's two openings in this space. This is the labium minora located here. Labium majora is this area that's around here. So there's labium majora, labium minora, external urethral orifice, and the vaginal canal. Here is a prepuce. So remember I said there was a prepuce for the male, this is the prepuce for the female. It's like a little hood or foreskin for the male. And this covers over the glans penis that's glans clitoris that's located right here, which is the same homologue as the penis in the male. And well, for the sake of time, I'll jump to that in just a moment. Here's our perineal body that's located here, and we have the anus located posterior. So let me show you some of these homologues real quick. All this are redundant pictures, a lot of them. But, so I added a couple of these things on here just to grab them real quick, so you can see some of the homologous structures that are associated with this. So for females, ovaries, males, testes. The ovum is the same as the sperm cell. Labium majora is the same as the scrotum. Labium minora is the same as the spongy urethra. Vestibule is the same as the membranous urethra. Bulb of the vestibule is the same as the corpus spongiosum and the bulb of the penis itself. Clitoris is the same as the glans penis, okay, and the corpora cavernosa. Periurethral glands, same as the prostate. The greater vestibular glands, same as the bulbourethral or Cowper's glands that are there. This is the PowerPoint that is going to be added in a second. I had to email it to myself because I had problems uploading it with my laptop, but I'll upload it shortly. This is also showing you kind of the same thing. I just grabbed it off Reddit. I want to see pictures, you know, and these are the best I could find in like 5 minutes, but really I'm sure there's some better ones that are out there. But just wanted you to see that, to see the relationship of those structures. Okay. So from this, I want you to note here the urogenital triangle. This is important to understand. So we do have, here's the ischial spine that's here, ischial spine that's there, but note those are not making the edges of this triangle. What's marking the edges of this triangle? The ischial what? Tuberosity, yeah, the part that hurts when you've been sitting on those hard bleachers for too long, right? So this ischial tuberosity is what we use as the edges of this. The pubic symphysis and the coccyx are the anterior-posterior aspects of it. So where these tuberosities line up is the central port of the perineum that we have that's located there. So here's our urogenital triangle up here. Our anal triangle is right back here. Again, we've seen these levator ani muscles, and coccygeus again we add for the part of the pelvic diaphragm. Notice we have 1, 2 levator ani, 1, 2, 3, including the pelvic diaphragm is all of this. So levator ani and pelvic diaphragm are not the same. Pelvic diaphragm is just a subset, levator ani muscles are a subset of the pelvic diaphragm that's there. As we do deeper cuts, you can actually see more of the structures. So here's some of the, here's more of our compressor muscles that are associated with these structures. Here, external urethral sphincters, okay? You can also note that here. There's vascularity, especially these perineal vessels that are coming into this perineal area. So all these vessels are here to innervate all these structures. This is where our pudendal nerves and things start reigning as king or queen in those areas. Okay. Also showing you some of the relationships. Notice that we have the body of the clitoris. People only see this, but But the reality is all of this, the crus and all of this, help to make up this clitoral region. All of this engorges during that time, okay? As we can see here, here's our spongiosum, here's the corpora cavernosum. All of this stuff engorges during that time in arousal. So crus are like legs, so you can see the crus, they can see the crus on each side. Again, here's bulbs, bulb, greater vestibular glands that are here. Cowper's glands would be the same thing as this greater vestibular for the males, that would be here. Those yellow ones that we saw in a previous picture. And now you can see more of the way these structures are related. Ischiocavernosus here, ischiocavernosus here. We have the perineal body where all of this stuff is coming together. Perineal body also where all these things are coming together. And the external anal sphincter being able to help keep things where they're supposed to be. Okay. And a lot of these become redundant. These are repeat pictures. This one is nice, because this allows us to see the sacral plexus and the pudendal nerve. Notice the pudendal nerve branches off from the sacral plexus, and it hits the inferior anal or rectal. It goes to the deep superficial, goes all the way out here to the dorsal nerve of the penis or the clitoris, goes down to the perineal nerves as it comes through, posterior scrotal, labial. So you can note, if we're talking about any erection stuff, if you mess up that pudendal nerve, folk are not pleased. So pudendal is the privates, right? It's very important for us that's there. Just showing you the vasculature that's there again. Arteries and relationships. Remember this? Piniform plexus, right? As they come down into the scrotal region. Okay. Again, showing you the pudendal nerve and how it's innervating these other structures in this region. Vater ani and some gluteal muscles in the back. Yeah. Okay, so that's all of that. That's pretty much just about there. Here's the pelvic exam review that's there. It's kind of bare bones, but essentially all structures are relationship to one another in the pelvis. Look at pictures, okay? Bladder development, bony pelvis parts. Do not forget testes development as well. Remember, testes develop up here and then they drop down to the scrotal area around before 6 months. So you want to make sure by 6 months you pull those testes down, or else they may have testicular cancer if you wait too long. Branches or be infertile. Or be infertile. So you got to pull those things down. Bony pelvis parts, branches and arteries of the veins of the pelvis. Buck's fascia, we saw that on the penis itself. Constituents of the sperm. What makes up the sperm? And those different components. Equivalent parts between male and female anatomy. Hemorrhoids. Remember, hemorrhoids are varices. Kind of look that up in terms of the portal venous problem that's there. The vater ani muscles, ligaments in general. Male and female pelvis, differences between those. The muscles in the pelvis, origin and insertions in general. Know where the internal, I guess all these guys, the internal and external obturator muscles attach. Make sure you're comfortable with where the pudendal muscles attach, and with the floor of the diaphragm muscles where they attach to as well. Penis and vaginal parts, perineal boundaries. Review some fascial layers, urogenital hiatus, triangle, and uterine artery. Is there anything I'm missing? I think the recesses. Make sure you're comfortable with those as well. So there's an area in which where you have the bladder and those kind of things that, I'm going to see if I have a picture that's here. This is a little better. So they call them pouches. So make sure you're comfortable in understanding that this is the utero-rectal pouch area that's here. This would be the utero-vesicular pouch. It's located here. So make sure you're comfortable in knowing what those recesses are. Those are things I've tagged in the past as well for practicums, because it's on Netter. So it's stuff in which you need to become aware of, because they like to use that as a landmark to describe where things are located. So I'll see you guys on Thursday. This Thursday, what's happening? Practicum, right. So we're going to use our atlas. We're going to study that thing, make sure it's our own. We're going to go to the bodies and start discovering a whole bunch of stuff that's there. Today I will have to go ahead and go over to body number 4 and remove the liver.
Sorry, I was trying to choose between 2 and 4. 2, the structures are just too small to really well appreciate. So I have to go into the lab today to make sure I remove the liver. We were able to see the biliary tract that's there for body number 4. So man, make sure you're tight on your celiac trunks and all those branches that are coming through stuff. Make sure you're comfortable in all the branches coming off. Gastroduodenal, all that stuff is fair game. Okay. Relationship with those structures that are there. Make them your own. Quiz each other on these. Say, what is this? What is this? What is this? That's the best way for you to get it. See you guys on Thursday at 11:30 in the lab. We're not going to be here.